Good afternoon, students. I'm Dr. Teddy from Department of Orthopedics. Today, my topic is one of the topics for 9th term, and that is a fracture shaft of femur. So, we have some topics regarding femur in 9th term. That is, one is fracture shaft of the femur. Others are like fractures of neck of femur, intertrochanteric fracture, that somebody will be taking, either I will be taking or somebody else will be taking subsequently. So today anyway the topic is fracture shaft of femur. So this usually comes as a long question for 10 marks, 20 marks, whatever it is. So you need to know the etiology, clinical features, diagnosis and treatment in a little bit of detail. So we'll just cover that briefly. So as you know very well, femur is in fact the largest and the heaviest bone in the body. That is quite obvious because it is quite thick and strong. It has to support the body weight, so it's quite heavy and large. It transmits a person's body weight to the tibia while standing. All these things you already know. And it has an anterior bow. You might have seen it in the anatomy class. It has an anterior bow. That is how you, it's a classical significant feature of the femur. The shaft of the femur is mostly smooth, as you might have seen, and it is rounded except posteriorly. And of course the linea aspera, again you know from your anatomy class, which provides attachment to the adductors of the thigh. So especially prominent at the middle third of the shaft, where it has medial and lateral lips. So that is in brief about anatomy. I think you already learned in your anatomy class. This is of course a diagrammatic representation of the anatomy of femur. Again, I'm not going into detail there. You already know these parts from your anatomy class. So some things are important here, like for example the head, the neck, because again they are important from a fracture point of view, which we'll be discussing later. So you know the lesser trochanter, the gluteal tuberosity, and of course the linea aspera, which is quite visible there. Then of course the medial and lateral, the intercondylar fossa, the condyles themselves, the medial condyle, the adductor tubercle, lateral condyle, medial condyle, all those things you already know. So that is very briefly about anatomy of femur. This of course shows very briefly about the muscular attachments of femur. Again, we are not going into detail there. You can see the adductors, then you can see the vastus lateralis, intermedius and the medialis. Then of course the tensor fasciae latae, sartorius, all those important muscles which I already learned in your anatomy class. So this is very briefly just to refresh your anatomy about the femur. Then of course the gluteus medius, minimus, maximus, all those attachments as you can see there. Then of course the other parts also, like the anatomical parts, like the sacrum, coccyx, all those things are visible there. So you can just have a look. This is very briefly about the muscular attachments as far as the femur is concerned. This is of course the blood supply in and around the femur. This is in fact blood supply is a little bit more important when we come to topics like neck of femur fracture. That is a little bit more important there, but of course you need to have an idea about the whole of the blood supply in brief about the femur, in and about the femur. So you can see the femoral artery, the profunda femoris, the deep branches, lateral circumflex femoral artery, perforating arteries, all those things. Again, we will be discussing it in a little bit more detail because the blood supply becomes even more important when we discuss topics like fracture, neck of femur. Here, you need to have an idea about the blood supply and as far as the fractures are concerned, so we'll be discussing that. So that is in brief about the blood supply. This is of course an X-ray. I think you already have an idea about the AP views and lateral views, which are usually used for majority of the bones as far as orthopedics is concerned. So here, we just have a very simple X-ray. We'll be discussing the details as far as fractures are concerned a little bit later. Coming in brief about the fractures of the shaft itself. Like for example, the femoral shaft fracture is usually defined as a fracture of the diaphysis. You already know the parts, the epiphysis, diaphysis, all those things you already know as far as the anatomy is concerned. So how do you define a fracture of the femur? It has to be a fracture of the diaphysis occurring between 5 centimeters distal to the lesser trochanter and 5 centimeters proximal to the adductor tubercle, because here 5 centimeters distal to the lesser trochanter, because above that you have the head of the femur fracture, neck of femur fracture, and becomes a subtrochanteric fracture if it is above that. So it has to be distal to the lesser trochanter. At the same time, it has to be above the adductor tubercle, because if it is below the adductor tubercle, it becomes a condylar fracture or intercondylar fracture or whatever it is. So here it has to be between that particular area, that is 5 centimeter distal to the lesser trochanter and 5 centimeter proximal to the adductor tubercle. Then only you can call it specifically a fracture shaft of the femur. It is usually always associated with very high energy accidents like road traffic accidents, high velocity road traffic accidents, especially in the younger age groups. That is the most common etiology as far as fracture shaft of femur is concerned. One important and interesting point to note here is the femoral shaft is usually circumferentially padded with large muscles. As we have already seen that small diagram we saw regarding the muscles. There's a lot of muscular attachment around the shaft of the femur. So that acts as an advantage as well as a disadvantage. The advantage here is it provides improved healing potential due to the good vascular tissue coverage. Because of along the muscles you'll also have a good vascular supply. But at the same time, it also can act as a disadvantage because the reduction becomes difficult because there's a lot of soft tissue and muscle padding is there. So when you are trying to reduce the fracture, it becomes a little bit more difficult compared to some other superficial bones, like for example tibia or something like that. So here the reduction becomes a little bit more difficult. So it can act as an advantage as well as a disadvantage. Again, etiology very briefly, like I already mentioned, usually it's high energy and it is very common in younger population as a result of MVA, that is motor vehicle accidents. Whereas in the elderly age groups, usually we always encounter fractures like neck of femur fracture and intertrochanteric fractures in older age groups. But of course, this shaft of femur fracture can also happen in the elderly. But there it is more common due to a fall from standing, maybe a gunshot injuries, of course, which is not very common in our country. But in Western countries or something like that, you can always encounter something like that due to gunshot injuries or something like that. Then there is something called a spiral fracture, I think, which you already learned in the general class about fractures. You already know what is a spiral fracture, which is usually caused as a result of twisting injury, like skiing accidents or roller skating accidents, maybe football injuries and all those things. Transverse and oblique fracture as a result of direct violence. It can be comminuted and segmental fracture, again as a result of very high energy trauma. So that is very briefly about the etiology of fracture shaft of femur. Now this is a very important named classification as far as femur fracture is concerned. It's called the Winquist and Hansen classification, which is very commonly used as far as clinical practice is concerned. It is again briefly divided into 5 types from 0 to 4. That is type 0, which shows no comminution at all. I'll just show a diagrammatic representation later. You can just have a note of this. There is type 1 is insignificant butterfly fragment with transverse or short oblique fracture. Now a butterfly fragment is nothing but, that is a very common term which is usually used as far as surgical orthopedics is concerned. A butterfly fragment is nothing but it's a meeting point between two oblique fragments which results in the formation of a fragment like a shaped like a butterfly. Like it becomes a floating fragment. That is what is usually, so where two oblique fractures meet, that is where you get what is known as a butterfly fragment. So in type 1, it is an insignificant butterfly fragment. It's not very big. We'll just come to that. Type 2 is a larger butterfly fragment, but less than 50% of the bony width, but more than 50% of the cortex intact. I'll just show the diagram there. So you can see the picture here that clearly shows the size of the butterfly fragment. As you can see here, in type 1 it is very small, type 2 it becomes bigger, type 3 it becomes even bigger, and type 4 it becomes comminuted. So that's how you classify. So we'll just go back to that. So you can see here, type 1 is an insignificant butterfly fragment, whereas type 2, which obeys these criteria, that is less than 50% of the bony width and more than 50% of the cortex is intact. That is what is called a type 2. Type 3, it becomes even bigger. The butterfly fragment becomes even bigger, which leaves less than 50% of the cortex in contact. So you can see there, in type 3, it's quite a large butterfly fragment where the cortex is, very small portion of the cortex is actually touching the rest of the bone. So that is why the cortex is very much not in contact. So that's why you call it a type 3. That is a larger butterfly fragment. And type 4 is quite obvious there. It is nothing but a comminuted fracture, which is breaking into more than 2 pieces, 2 or more pieces. So there you can see that segmental comminution. That is in more than one place. That is comminution in more than one place on the same bone. That is known as segmental comminution. So anyway, just remember this classification. That is from type 0 to type 4. That is known as the Winquist and Hansen classification. So based on the butterfly fragment and its position and attachment and all those things. So I hope that's kind of clear. Coming to clinical presentation. So that's again quite obvious. You already know all the common signs and symptoms as far as a fracture is concerned in general. So here naturally there will be a pain in the thigh. Obviously there will be more or almost always there will be a history of trauma, road traffic accidents, maybe less commonly explosives, gunshots. Then again, which I already mentioned, sports related injuries like skiing, climbing, high velocity trauma and all those things. So these are the common. As far as all the things will be there, like severe pain will be there, swelling will be there. You already know the signs and symptoms like immobilization of the concerned part, severe swelling, tenderness, abnormal mobility, all those general signs and symptoms which you already learned about fractures. All those things will be more or less present here. obviously, because it will be present quite obviously because it's quite a big bone, and the fracture will also be comparatively bigger compared to other areas. Coming to physical examination, again, very briefly, you can see inspection naturally, you can see all those things. There will be tense and swollen thigh. Thigh will be very severely swollen and will be very tense. Now, a very important point always to be kept in mind as far as femur shaft of fracture shaft of femur is concerned is always a hypovolemic shock. This is very important as far as femur is concerned. Then other fractures where it can become a problem is pelvic fractures like the pelvic girdle and all those things. But here it is much less common in other bones. Even in tibia it's not that common compared to femur or anything like that. Because whenever you get a femur shaft fracture, the most important complication you always need to remember is not the fracture itself, it is always a hypovolemic shock, which becomes a life-threatening situation. So you need to, we'll just see that briefly. There you need to correct that first. You need to save the life of the patient first, and then only you need to concentrate on the on fixing the fracture itself. So that point should always be kept in mind as far as fracture shaft of femur is concerned. So here, as you know very well, the total circulating volume of blood in the human body is around approximately 5 liters. So here, as you can see, it can result in approximately a loss of 1.5 to 2 liters in fact. So you can see almost half of the blood, two-thirds and almost that much of blood can be lost in case of a fracture shaft of femur. So that's why it becomes a life-threatening situation. The patient goes into a hypovolemic shock and obviously the patient can die if you don't correct the situation. Whereas in closed tibial shaft fractures, it can be less, like around 500 to 1000 ml. Of course, still significant, but not as significant as in case of fracture shaft of femur. And in open fractures, sometimes the blood loss can be double that of closed fractures because it's not only bleeding internally into the body, it can even bleed outside obviously because it is an open fracture. So there it becomes even more important as far as blood loss is concerned. Then of course, so that point should always be kept in mind whenever you discuss fracture shaft of femur. And of course, naturally, an important symptom or a sign the clinician can observe is always a distal neurovascular status will be compromised. Obviously, when there is a lot of blood supply, when a lot of loss of blood, obviously as well as some nerve damage can also occur. Again, I'm not going to detail that. So you can obviously observe some kind of it may or may not be present. Neurovascular status may be compromised if you try to feel the dorsalis pedis artery or something like that. That is more of clinical examination. That can also be compromised as a result of fracture shaft of femur. Again, the attitude of the limb you need to observe. Like for example, attitude of the limb means the position of the limb when the patient presents himself or herself. You can see the position of the thigh. Based on that, you can straight away come to a conclusion what fracture it is or what part of the leg is fractured. For example, in proximal shaft fractures, the proximal fragment is flexed, abducted and externally rotated because of the gluteus medius and the iliopsoas pull. So again, that is more important as far as the pull of the muscles on the bone fragment is concerned. So here, what happens in proximal shaft fractures, you can just keep in mind an interesting point. The fragment, as you know very well, any fracture should have at least a proximal fragment and a distal fragment. So here, the proximal fragment will be flexed, abducted and externally rotated because of gluteus medius and iliopsoas pull, whereas the distal fragment is frequently adducted. So that is why I said the attitude of the limb also becomes an important clinical symptom, clinical sign as far as this particular fracture is concerned. This is just an example of why the attitude of the limb becomes important. Whereas in mid-shaft fractures, the proximal fragment is flexed and externally rotated, but the abduction is less marked. That is in a mid-shaft fracture. Whereas in lower third fractures, the proximal fragment is adducted. So you can see the difference there. And the distal fragment is tilted by the gastrocnemius pull. So again, we need to go into detail in anatomy there, but you can just remember these points. Why the attitude of the limb becomes important. So three classical examples they have given. Why the attitude will be different in these three different types of fractures. That is in proximal, mid-shaft and lower one-third fracture, a shaft of femur. So that is why it becomes important. So you can just keep that in mind. It's an interesting point there. The soft tissues are always injured and bleeding from the perforators of the profunda femoris may be severe. We have already seen the blood supply in and around the femur shaft. So there, the profunda femoris again, femoris, as you can see there, why the soft tissues, because there's a lot of soft tissues we already seen covering the shaft of femur. So they are, especially in open fractures, there will be almost always these soft tissues will be injured and bleeding will be taking place. One important point, again, interesting point you can remember is you need to be very careful of the fracture of the junction of the middle and the distal thirds of the femoral shaft. Why? Because it can be responsible for damaging the femoral artery in the adductor canal. So that point you can just remember. Why a particular fracture at that particular point becomes even more important. That is the junction between the middle and the distal thirds of the femoral shaft. Because there's always a chance of damaging the femoral artery. And as you know very well, femoral artery being such a big and important artery, obviously if injured or damaged, it becomes a severe critical situation where the blood loss will be very high and you will struggle to revive the patient. Reviving the patient becomes extremely important because the femoral artery itself is damaged. So with such high blood pressure and loss of blood, it becomes a severe life-threatening situation. So that is why you need to be specifically careful of the fracture at that particular point. So that's an interesting thing you can remember. Some other fractures to rule out along with the fracture shaft of femur: ipsilateral femoral neck fracture. That is, ipsilateral means the same side. So along with the fracture shaft of femur, if it is a very high velocity road traffic accident or something like that, you need to rule out a femoral neck fracture, which can occur in around 10% of such cases. Pelvis fracture, like I already mentioned, you need to examine the pelvic girdle and all those things. Why? Because again, pelvic fractures are also kind of notorious for loss of blood and going into hypovolemic shock and all those complications. So again, you need to rule out, along with femoral shaft fracture, you need to rule out if there is a pelvis fracture along with it. Fracture of ipsilateral tibia, that is known as a floating knee. A floating knee is nothing but when the fracture shaft of femur and shaft of tibia take place on the same side, then you call it a fracture, a floating knee. That term, it might be a short note or something. What do you mean by a floating knee? That is ipsilateral fracture shaft of femur as well as shaft of tibia. That is what you call floating knee. Similarly, you can get a floating elbow also, like for example, if the humerus and radius both are fractured, then you can call it a floating elbow. So similar to that, there is something called a floating knee. So again, you need to rule that out whenever you get a case of fracture shaft of femur. And of course, patient should be evaluated for chest injury, head and abdominal injury, because we already mentioned the major etiology for such fractures is always very high velocity road traffic accidents. So obviously, there might always be some kind of accompanying injuries, like for example, life-threatening injuries like chest injury, head injury, abdominal injury and all those things. So those things also you need to rule out along with fracture shaft of femur. So that is why it becomes more important to rule out such cases. Then of course we'll come to investigations, diagnosis. Again, as usual, the commonest views we take, I think you're already aware of that, AP and lateral views of the entire femur, the whole femur length. You need to take anteroposterior and lateral views, as well as AP and lateral views of the ipsilateral hip, which I already mentioned. Why? Because the pelvis may be fractured, the neck of femur may be fractured in such cases. So you need to take out and rule out. You need to take and rule out such fractures also. So you need to go for AP and lateral views of the ipsilateral hip, as well as AP and lateral views of the ipsilateral knee. So in short, all those structures which are coming in and around or surrounding the shaft of femur, you need to rule out such fractures so that you don't miss any of those fractures. Right? So that is the basics about this thing. Then in briefly you can remember the 4 R's of fracture management. Now the thing is, this is specifically important in case of fractures like shaft of femur fracture. These 4 points are important in any fracture, but here it becomes even more important because fracture shaft of femur is a life-threatening situation. So there, the first R, you can say it stands for resuscitation. That is done at the site of the trauma or the emergency room. It comprises the addressing of the acute life-threatening, which I already mentioned. Life-threatening condition related to the fracture or the trauma, like blood loss and all those things, hypovolemic shock. The second one is of course reduction. Reduction means bringing the fracture back into its anatomical position. That is known as reduction. There is definitive management of fracture done internally or externally. As you know very well, there are 2 types of fixation, internal and external fixation. Again, we'll see briefly regarding the fracture shaft of femur here. Third is retention. Retention means what? Stabilization of the fracture segment throughout the healing process. That is basically you're fixing the fracture, either using external fixator or internal fixator, and you have to maintain that fracture fixation. As you know very well, an adult human being, otherwise healthy adult human being, it takes anywhere between 4 to 6 weeks or 8 weeks for a fracture to heal. So throughout that period, you need to maintain or stabilize the fracture. That is known as retention. And the last one is of course rehabilitation. That is focusing on getting the patient back to his activities of daily life as soon as possible. There is of course rehabilitation, which includes physiotherapy and all those things which you have already seen. You might have experienced yourself, or someone you know might have gone through all these stages as far as a fracture is concerned. So these are the important points regarding any fracture, but here fracture shaft of femur, it becomes even more important. That is in a brief or in a nutshell about what you do regarding the treatment of a fracture. So management. Once the diagnosis of fracture shaft of femur is established, what are the steps we can take in the emergency room? That's already mentioned. Why that? Because it's a life-threatening situation. First one is, we already seen that, resuscitation or management as per the ATLS protocol. What is ATLS? That is nothing but Advanced Trauma Life Support. That is a very useful common course. I think it's offered by the American College of Surgeons for managing any acute trauma case. It is a very famous course worldwide where the surgeons are trained to treat any kind of acute trauma patient. So as for they have a particular protocol of what to treat and all those things. Some of you might be aware of that already. So it has to go according to the ATLS protocol. Second one is of course immobilization using splints. That is, for example, splint is what? For example, you need to transport the patient from the site of the injury to the hospital. There of course you cannot put a POP cast or something and transfer the patient. You need to temporarily immobilize the patient. So there you put a splint and then transfer the patient to the emergency room or hospital or whatever it is. Then elevation of the limb that already comes in accordance with the treatment of the fracture. So these are the initial steps which you need to take as far as management is concerned. Then of course we'll come to specifically the fixation of fractures. Fixation of fractures, whether it's open or closed or whatever it is. First important point you can already notice, known as traction. I think again you might be aware of what is traction, which is a very commonly used term in orthopedics. There's something called skin traction, there is something called skeletal traction. All those things you might have been, I think some classes already taken, or you might be aware of the basics there. So here it can be used by treated by traction. That is basically we are discussing the non-operative method. As we will see later, the gold standard for treatment of a femur shaft fracture is always operative. It has to be, preferably it always has to be operated. But here, if at all you have to treat, let's say, again, we'll discuss those situations later. Why in certain situations you need to treat the patient non-operatively or conservatively. So there you can use what is known as a traction. That can be used with or without a splint. Usually a Thomas splint, you might have seen it in the OPD. A Thomas splint is a very commonly used traction device in orthopedics. It was originally invented to treat tuberculosis of the knee joint. But here, as far as fracture shaft of femur is concerned, it is the gold standard now for immobilizing as far as the hospital stay is concerned. It is the specific type of splint which is commonly used for treatment of, for immobilization of fracture shaft of femur. Skin traction, okay, so Thomas splint is usually used in adults, or whereas in children, sometimes more or less skin traction may be sufficient. Skeletal traction in adults is given by Steinman's pin. I think you might have, somebody might have taken the instrument class. If at all you might have seen the instrument class, you might have seen something called a Steinman's pin. There's also something else called a Dunham's pin. These are usually used for skeletal traction. Skeletal traction means what? As the name suggests, it goes through a bone. You drill a bone, you put this pin through the bone, and then you attach weights to the that pin. That is known as a skeletal traction. But nowadays, it is very less used as far as orthopedics is concerned, because it's a very cumbersome process. Of course, the patient is permanently, means like, as far as the patient is completely immobilized. They won't be able to get up or do any kind of activities or whatever it is. It's almost like you are like immobilizing the patient on the bed, because naturally it is a skeletal traction. So there it becomes very difficult. So nowadays it's a cumbersome process. It is not very commonly used, but in specific situations you need to use it. So here skeletal traction can be given in adults, where you decide to treat the patient non-operatively. You can use Steinman's pin for skeletal traction, specifically through the tibia. Sometimes here what I mean to say here is different. How you treat the femur shaft fracture differently in children and in adults. For example, in children up to 2 years you can use something known as a gallows traction. Again, I have a diagram for that. Whereas in an older child, you use what is known as a Russell's traction. Again, we are not going to detail about tractions, it's a totally different topic, but you can just remember, in children up to 2 years approximately, you can use what is known as a gallows traction. Whereas in an older child, like 3 to 6 weeks, above that, you can use what is known as a Russell's traction. Whereas in 2 to 16 years approximately, different methods. Of course, these age groups are not 100% specific. That is an approximate age group. You can use different methods of traction can be used, following by immobilization using a hip spica. Hip spica is again something that is made out of casting material that is used to treat a variety of conditions in orthopedics, congenital deformities and all those things. You might have read about a DDH, developmental dysplasia of hip, or maybe lot of things are there, like congenital deformities as well as traumatic injuries. All those things can be treated in children using a hip spica. So I think you may have seen it somewhere. This is an example of this is an example of a gallows traction. So you can see how the small child is treated using a gallows traction. Whereas this one, you get the lower diagram, that is known as a Russell's traction. That is an older child. We have seen there, as you know, as you can see there, the thigh and the knee joint, they are elevated. That is what is known. That's the difference there. That is known as a Russell's traction. That first picture is nothing but a Buck's traction. Buck's traction is not an example of skeletal traction. It is an example of a skin traction. There is no invasive procedure involved. You just apply a plaster to the skin and attach the weight. So that is known as a Buck's traction. We don't need to concentrate on that. If you concentrate on the second picture, that is known as a Russell's traction. That is what we use in femur shaft fracture, can be used in older children. And third one is what is known as a hip spica. So this is what is known as a hip spica cast. This is not specifically used only for femur shaft femur fracture. It is used for a variety of conditions. One of them is femur shaft fracture. I mean fracture shaft of femur. So that point you need to remember. So that is very briefly about children, right? We'll come in detail about adult treatment. So that's, you can just keep in mind what exactly these types of traction are. Right? A little bit about Thomas splint, which I already mentioned, because it is a very important tool used in fracture shaft of femur. Indications, when do you use it, which I already mentioned earlier, when the patient is medically unfit for surgery. Like I mentioned, if possible, you always operate on the patient, because that is the best treatment for shaft of femur fracture you can give. Whereas if the patient is medically unfit for surgery, or let's say polytrauma, where there's a lot of injuries on the patient, right? Stabilization when immediate surgery is not possible or practical due to some kind of generalized condition of the patient, you might not be able to immediately operate on the patient. Right? In such conditions, you can use a Thomas splint, but of course, it has a few disadvantages also. So, what are those? Overlap of the fracture can occur despite traction. Like, it's not a definitive treatment, or it's not the best treatment you can give. So, obviously, it will have some disadvantages. Continuing motion at the fracture site, it is not complete immobilization. You're not able to completely immobilize, because after all, it's only a splint. So you cannot completely immobilize the fracture. So it will still, the motion or the movements will still take place at the fracture site. So that is a major disadvantage. And continuing soft tissue compromise and bleeding, those things cannot be prevented using a Thomas splint. So it has its advantages as well as disadvantages. So in such cases where you cannot operate on the patient, use a Thomas splint. Coming to operative treatment, which I already mentioned, most femoral shaft fractures are treated with intramedullary nailing. Again, I think you might be aware of that term. Intramedullary nailing is one of the commonest types of surgery used for trauma in orthopedics. So as the name suggests, you might have seen the different types of intramedullary nail if the instrument class was already taken. We have different types of nails for different bones. So here, that is usually the best treatment you can give for fracture shaft of femur. So where it passes through the medullary canal. So intramedullary nail, there are different types of IM nails will be there. That's all different topic. So that is the best treatment you can give, because it gives the strongest mechanical fixation and is the best treatment for early mobilization. So that is basically what you can say the gold standard for treatment of fracture shaft of femur. So whenever it's possible to operate on the patient, you go for this type of treatment. That is IMIL. That's nothing but intramedullary nailing with interlocking. That is what is known as IMIL. Intramedullary nailing with interlocking. Interlocking is nothing but using screws to lock the nail into place. Again, if you see a picture or an X-ray or something like that, we'll be able to discuss that in detail, where you use something known as proximal screws and distal screws. Basically, there's something called unlock nailing and lock nailing. So here, nowadays what we use is known as the interlocking nailing. That is basically you're locking the nail into place using two sets of screws. That is proximal screws, that is near the knee joint, and the distal set of screws, which you use near the ankle joint. So that is known as interlocking nailing. So what are the indications where you can use IMIL? All patients with femoral shaft fractures except those not fit for definitive surgery, which I already mentioned. Isolated fractures, fracture shaft of femur. Closed fractures, where the fracture is not open. If the fracture is open, what will happen is we need to go for an external fixator. I think you already mentioned that one of the most important indications for external fixation is open fractures or compound fractures. So here, in closed fractures, you can straight away go for IMIL. Gestilo types 1 and 2 open fractures. Gestilo is nothing but a classification used to classify open fractures or compound fractures. It's known as Gestilo and Anderson classification. It is classified into type 1, type 2, type 3, A, B, and C. So type 3 is classified into type 3A, B, and C. So type C, 3C is the worst, where you get a lot of vascular compromise, where the artery is also damaged. So here, Gestilo and Anderson types 1 and 2, where the wound is less than, like they say, around 2 to 10 centimeters. That is 1 and 2. Less than 2 or 2 to 10 centimeters. In size. There you can use what is known as IMIL can easily be used. So 1 and 2 millimeter size, less than 2 or 2 to 10 millimeters in size. There you can use what is known as Gestilo types 1 and 2 fracture. Such types of classification you can use IMIL straight away. Polytrauma patients in stable condition, where there's a lot of polytrauma patients are there. Like, we can say the patient has a lot of injuries, polytrauma patients, a lot of associated injuries. There you can use IMIL nailing. So these are the indications where commonly use the gold standard, that is IMIL nailing for fracture shaft of femur. What about contraindications? Where can you not use IMIL? Again, so just the opposite of what we already discussed. Whereas where the polytrauma patient is in unstable condition. So even though the patient has polytrauma and is stable, you can use IMIL. But if the patient is unstable, then you cannot use IMIL. Then of course not medically fit for surgery. Then image intensifier unavailable. Image intensifier is nothing but a kind of intraoperative X-ray. You might have again seen it in the OT. It's nothing but a C-arm. It's also called a C-arm. It is shaped like a C, where you operate under the X-ray. It's kind of like you can call live X-ray. You're taking the X-ray and operating. So in a lot of orthopedic surgeries where you need to put in an implant and all those things, you need a live X-ray where you can operate under the X-ray. That is what is known as an image intensifier, commonly known as a C-arm. So in such in small hospitals or in primary health centers and all those things, you might not be able to get an image intensifier. So there you need to go for you cannot use like IMIL, where because it's a precision kind of surgery where you need to insert the implant precisely through the medullary canal, and you may need to open the fracture site, and all those things will be there. So you need to have a C-arm. Without a C-arm, it is not possible. So in such conditions, you cannot go for IMIL. Associated vascular injury requiring open repair. So if the vascularity is compromised, there you may need to open up the injury site, open up the fracture site. So there you need to go for, you cannot use IMIL, right? Periprosthetic fractures. That is, if the patient already has an implant, let's say due to some previous fracture or something like that, and the fracture has taken place around the prosthesis, right? Prosthesis is intact, or what we call in situ, and there are fractures occurring around that prosthesis. There you cannot straight away go for IMIL. Then continuing infection. If the wound is already infected, obviously you cannot put an implant in when there is an active infection. Occluded intramedullary canal. Obviously, to pass an intramedullary nail, the medullary canal should be open and clear. So if due to some reason the intramedullary canal is occluded due to some obstruction or whatever it is, obviously you cannot go for IMIL. Gustilo types 3C, that is already mentioned. 3C is the worst, where you get articular, where you get vascular compromise, artery may be damaged, and all those things. In such cases also, it is not possible to do IMIL. So if these contraindications do not exist, you can very well go for IMIL. So those are the indications and contraindications. In brief about advantages, it is a less invasive procedure comparatively, you can say. Then it minimizes soft tissue damage, the fracture can be reduced, right? Then better biomechanical properties, it's a definitive procedure, rapid mobilization of patients. That is one important advantage of IMIL. So if all the conditions are met and if you can do IMIL, then it's very good that you'll be able to mobilize the patient fast. Minimal blood loss, good cosmetic results. So all these are advantages as far as IMIL is concerned. So apart from the contraindications, if possible, always go for IMIL. Disadvantages? Again, risk of iatrogenic femoral neck fracture. While operating, you may end up, fracturing, the femoral neck. Not very likely, but possible. So that is one disadvantage. Risk of fat embolization. There's something called reaming and all those things. When you're trying to put the nail into the intramedullary canal, when you ream the nail, the canal, what happens is it might release some fat globules into the bloodstream, and that can cause fat embolism and all those things. Risks will be there. Closed reduction may be more challenging than open reduction. Open reduction means you're opening the fracture site. Closed reduction means you're only using a C-arm. You're not opening the fracture site. So that is known as closed reduction. So that is obviously more challenging compared to open reduction. Frequent use of image intensifier, risk of increased radiation exposure. Like I already mentioned, it is nothing but a portable, not portable, it's nothing but a live X-ray. So the more you use an image intensifier or a C-arm, the more all the people in that OT are exposed to radiation. They're all exposed to X-ray radiation. So naturally, you need to minimize the amount of radiation you are exposed to. You need to have the proper gear, like a lead jacket and all those things. If that is not available, and then you are risking yourself, as well as all the people in the OT, to more radiation exposure. That, of course, in the long term, it can become carcinogenic. So that becomes very important there. So in such cases, you need to avoid IMIL. So these are some of the disadvantages as far as intramedullary nailing is concerned. So this is a picture of how it is done. You can see there the intramedullary nailing there. The nail, you can see the proximal locking near the hip joint, and you can see the fracture site, and the nail is going through the fracture site. And you can see the distal, so what I mentioned earlier, you can see the proximal screws near the hip joint, and you can see the distal screws near the knee joint. So that is known as, this is a classical example of what we call locked intramedullary nailing. Like I already mentioned, places without facilities of C-arm, you can use something known as K-nail. Again, that is not very commonly used because most of the big hospitals will have C-arm and all those things will be there. But they can use a specific type of intramedullary nail known as K-nail. Which is not commonly used nowadays, but it can be used where the C-arm is not available, right? It is most suited for a transverse or a short oblique fracture. It is not preferred for a comminuted fracture, as this cannot provide adequate stability. Again, it is not very much in common practice now because most of the hospitals do have better facilities. So there you don't use it much, but you can always keep that in mind, where K nail, intramedullary nail, is used. Kushner's nail, right? It can be used. Clover leaf. It is shaped in the form of a clover leaf. It's a transverse section. Its cross section is shaped like a clover leaf. That is why it is called a clover leaf nail or K nail. Right? That can also be used. So these are just some pictures of the fracture as well as after fixation with the intramedullary nail. You can see that there. Then again, briefly, we'll come to the last part, that is known as the ORIF. ORIF is nothing but open reduction and internal fixation with a plate. Usually, these are the two commonest used internal implants. Nails, plates and screws. So nails and plates and screws are the two commonest implants which are commonly used in orthopedics for internal fixation. So gold standard for shaft of femur fracture is always a nail, intramedullary nail. But sometimes you need to fix it with a plate and screws. So what are the conditions where you need to fix it with a plate and screws? For example, all patients with femoral shaft fractures with the intramedullary nailing is contraindicated, which you already seen. What are the contraindications for IM nail? But the patient is fit for surgery. Specifically, IM nail is contraindicated, but the patient is very well fit for surgery. There you need to use what is known as a plate and screws. Indirect reduction is impossible, where you cannot reduce a fracture indirectly. That is without opening up the site. And again, no C-arm is possible. A C-arm is not available. Then you need to open up that fracture site and fix it with plate and screws, which you can do even without a C-arm. Early pregnancy after 12 weeks gestation due to the risks from radiation exposure. Again, you cannot use a C-arm there, and it's the early stages of pregnancy as far as the patient is concerned. So there you need to operate without using a C-arm. So there you can use a plate and screws. So those are the advantages of using a plate with screws in such situations. Again, polytrauma patients associated chest injury, then comminuted fractures, where again, because chest injury, I think because of the increased risk of fat embolism due to reaming of the intramedullary canal and all those things. And in comminuted fractures, also you need to use a plate with screws. Then what about the contraindications for plate? Patient, obviously the most important is not medically fit for surgery. Osteomyelitis, if there is active infection of the bone, you cannot use a plate with screws. And there is compromised local soft tissue. So just as a point you need to remember, the gold standard is always nailing. But in certain situations where you cannot use a nail, you need to go for plate and screws. That is the difference between the two types of internal implant. Again, very briefly about plate and screws. It is a less demanding procedure, less exposure to ionizing radiation, direct reduction can be used, all those things. Fracture stabilization of the plate reduces the incidence of fat embolization, which I already mentioned, due to IM nailing. Fracture stabilization allows for early patient mobilization, just like a nail. Disadvantages: greater blood loss as far as plate is concerned. Exposure of fracture zone or risk of interference with the healing process. That's again a disadvantage you can say. Larger operative soft tissue trauma, because you're more, you're dealing with the soft tissues more, you're manipulating the soft tissues more. Less appealing cosmetic result, not as much as a case of not as much as you get with case of a IM nail. There's always a risk of screws pulling out in osteoporotic bone. If the bone is osteoporotic, if it is soft, the screws can pull out. Whereas that doesn't happen with a nail. So such are disadvantages you can say with the plate fixation. As you can see here how the femur is fixed with the plate and screws. Already you have seen earlier how it is fixed with an IM nail. This one is fixed with the plate and screws, as you can see there. Again, as you can see here, there are different types of plates like DCP, LCDCP, LCP and all those things are there. That's a different topic. But again, this is in general about the fixation of plate and screws. External fixation you already know. So what we discussed so far are internal fixators, plate and nail. Whereas external fixators are always used for open fractures or compound fractures where there is a high risk of infection, where you cannot go for an internal implant. There you go for external fixation. That is those big steel implants which you might have seen, like some patients admitted in the ortho wards with huge steel frames around their leg or hand or whatever it is. They are known as external fixators. The most important indication for external fixation is open fractures or compound fractures. So in such cases you need to go for external fixation. What about contraindication of external fixation? Something about osteoporosis, because the bone is very soft. Of course, it can also cause what is known as pin tract infection. That is through the pins, where the pins are used to fix the external fixator to the limb. So those entry points can get infected. That is known as pin tract infection. So, and of course, it's a very cumbersome process. The patient has to lie down with all the huge steel frame and all those things. So these are the disadvantages of external fixation. But in such cases where you cannot go for internal fixation, it's a must. You have to go for external fixation only. So this is an example of external fixators. You might have already seen that. Such patients in the wards. That's known as external fixation. Again, same thing. There are different methods of external fixation are there nowadays. Advanced methods like Ilizarov technique and a lot of techniques are there. But external fixation in general, that is the indication. The most important indication is open fractures or compound fractures. So basically what happens is if there's an infection, temporarily you put in an external fixator. Later on you convert it into internal fixation. Once the infection subsides and the patient is stable, you convert it into internal fixation. That is with a mostly with a nail or sometimes even with a plate and screws so that the fracture can heal. That is the advantage of external fixation. The important point to remember is external fixation actually doesn't help in union of the bone. What happens is, as long as you put an external fixator, because of certain conditions, you have to put an external fixator. But here what happens is union of the bone will not take place. The fracture will not heal. You have to convert it into internal fixator later on for the fracture to heal. That is the disadvantage of external fixation. Coming to rehabilitation, already mentioned, that is physiotherapy, early mobilization of the patient, return to daily activities of life and all those things. Very briefly about complications, I already mentioned, most important is shock, that is hypovolemic shock. Second one is fat embolism. Even the fracture shaft of femur, without any operative procedure, the fracture itself can cause fat embolism. That's one important life-threatening complication of fracture shaft of femur. Then of course, again, I already mentioned that injury to femoral artery. That is again very important. Injury to the sciatic nerve. That is again important. So neurovascular compromise. That is an important complication of shaft of fracture, shaft of femur fracture. Then of course infection, especially in case of open fractures or compound fractures. One important complication is always infection. So these are the very important complications as far as fracture shaft of femur is concerned. Then of course the late complications like delayed union, non-union, malunion, all those things which are already discussed in general under fractures. So those are the important complications as far as fracture shaft of femur is concerned. So that's it. Yeah, so basically what happens is it can also lead to undetected knee injury, physiotherapy, all those things. Sometimes what happens, it can lead to prolonged immobilization, all those things can lead to adhesions around the knee joint where it becomes very stiff. Then you need to release those adhesions so that you can free up the knee joint and all those things. So these are all the important complications as far as immediate complications, as far as late complications, as far as fracture shaft of femur is concerned. So that's very briefly about fracture shaft of femur. These are important points. All the important points regarding the exam I already mentioned. So this can usually be asked as a long question, essay question, like etiology, clinical features, diagnosis and management, and a brief note about complications also. So that's all about fracture shaft of femur. Thank you very much. Thank you.